Two smokers. One patient keeps coughing for years. Every morning, lots of sputum. The other is breathless, but barely coughs. Same disease, COPD, but two different mechanisms. Let's understand the mucus side of COPD. I'm Nabeel, this is Pathocyte, and today we look at chronic bronchitis. Chronic bronchitis is cough plus sputum or productive cough for at least 3 months in a year for 2 consecutive years. And of course, no other cause should be found. If there is no cough, it's not chronic bronchitis. Smoking is the most important cause. 90% of people with chronic bronchitis are heavy smokers. Other causes include air pollution and occupational exposure to dust from grains, cotton, etc. With that basis, let's move on to the pathogenesis of chronic bronchitis. Chronic irritation due to cigarette smoke leads to enlargement of submucosal glands. This occurs initially in the large airways, but later on it spreads to the smaller airways also. Goblet cell hyperplasia also occurs here. This leads to increased mucus secretion. There is a lot of evidence that smoking leads to dysfunction of CFTR or cystic fibrosis transmembrane conductance regulator. This acquired dysfunction leads to the formation of dehydrated thick mucus. This adds to the insult as thick mucus is harder to clear. Damage to the mucosa leads to inflammatory infiltrate composed of neutrophils, lymphocytes, and macrophages. This inflammation leads to chronic damage. And the fourth factor is infections. Infections probably do not initiate chronic bronchitis, but they are very important in maintaining it, and they are the main cause of acute exacerbations. This leads us to the morphology of chronic bronchitis. Grossly, you see hyperemia, swelling, and edema of mucous membranes. Usually, airways are filled with mucus or mucopurulent secretions. And in many cases, you see thick mucus plugs. And under the microscope, you see goblet cell hyperplasia, chronic inflammation, and the most striking feature, which is increase in mucus glands. This leads to thickening of the mucosa, which is assessed by Reid index, which is basically a ratio of thickness of the submucosal mucus secreting glands to the thickness of the bronchial wall, that is basement membrane till the cartilage. Reid index is normally less than 0.4. In chronic bronchitis, it is more than 0.4. Reid index is increased. This increased mucus secretion along with mucus plugging, chronic inflammation, and repair through fibrosis can lead to narrowing of bronchioles, and in some cases it can be so severe that bronchioles are completely obstructed. This is called bronchiolitis obliterans. This brings us to our blue blotter. Patients with chronic bronchitis have chronic productive cough, reduced oxygen in the blood leading to cyanosis, recurrent infections as the mucus clearance is poor, and often cor pulmonale, basically heart failure because of problem in the lung. This cor pulmonale further leads to generalized edema. All of this makes the patient look like a blotted person, and the patient is blue because of cyanosis. So, patients with chronic bronchitis are called blue blotters, in contrast to patients with emphysema who are called pink puffers. In real world clinical scenario, these two diseases often occur together, although degree of each may vary. In the next video, we'll compare and contrast emphysema and chronic bronchitis. Think at the cell level.